Before I introduce our speaker, a little bit of housekeeping and then just a little bit to let you know about the National Children's Prom. So we are going to be recording the webinar today. So what we ask is that everybody keeps their camera off, apart from Rob and I, because the plan is that then it will be uploaded onto our website so that people can then revisit it at their leisure, look for any information and things that they thought was useful. So if people can have cameras off. And also really important to have your mics off as well. Sometimes we do hear about people's lunch and things, so that's helpful to do that. If we're having any questions, which I hope we're going to have lots and lots of questions, please can you put them in the chat? We're not going to be taking verbal questions today. What we'll do is we'll put them in the chat and then I'll pose them to Rob. Lots of nice difficult ones for him, please, today. And then Welsh slides are available on request. So just let us know. The other thing just to say is while Rob is talking, then the team will be populating the chat with lots of useful information that basically will be going through the chat. So anything that Rob then talks about, anything that he signposts to, the team will just be popping it into the chat so that you will have all of that information at your fingertips. But as well as that, my team or Sam from the team has developed a Padlet, which is all the information that you need to know about value-based healthcare with regards to children, babies, children, young people in Wales. And we will send that out to everybody after the webinar so that you can all have that for further information. So I think that's pretty much all of the housekeeping for today. But just before we move on to the main event of Dr. Rob Letchford, I just wanted to talk to you a little bit about what the plans are for PROMs, patient-reported outcome measures for children and young people in Wales. Now, as you know, there's a really big move towards getting that patient-reported outcome measures, and Rob's going to talk to you about them in way more detail and with much more knowledge than me. What we wanted to do was have one children's prom for Wales. The reason for this was because the children have epilepsy, they have asthma, they go to ED, they every single part of the health system will be interfacing, apart from geriatrics, will be interfacing with children. So what we wanted to do was have one way of measuring outcome. Now, as Rob will tell you in a bit, PROMs can do two things. So they can be something that you can measure an intervention. So you can either do before and after an intervention to see whether it's improved the outcome and whether people feel that it's been beneficial. But the reason why we're really interested in it from a child health network is we're hoping that by using a children's PROM, the same one, we're going to have an enormous body of evidence about children in Wales, babies, children, young people in Wales, and about their outcomes. And that will really give us a position on what children's health is like, what people perceive their health to be like, and what we can be doing. And that will really guide us about how we can do things differently in the future. So I'm going to let Rob talk in much more technical detail about this, but I really just wanted to say a plea really for that once it is rolled out, we've applied for a license for it. At the end of the presentation, we'll be able to share with you which one that's been selected and why we've selected it. But just a plea that once it is rolled out, it's really important. I know it feels like it is one more piece of paperwork or one more piece of thing that we have to ask people to do, but actually it's so important because if we're going to get our population's health needs right, we really need to know that what they need and what's working for them. So without further ado, I'm going to introduce you to Rob Letchford. So Rob is Dr. Rob Letchford. He's the current National Clinical Lead for Value-Based Healthcare in the Value Transformation Team in NHS Performance and Improvement. He's a consultant physiotherapist and has worked across clinical strategic, research, education and improvement pillars. He's led person-centred value-based system change across many different specialities, including his own specialty, which is musculoskeletal health and rehabilitation. So I'm so delighted that Rob agreed to come and speak to us today because he's a fantastic speaker, but also, his knowledge in this area is brilliant. So please, over to you, Rob. Oh, hang on, no, not over to you yet, because I'm to the Mentimeter. So I'm so sorry. That's a faux pas from the chair today. So everybody, hopefully everybody's apologies, Rob. Hopefully everybody's managed to click onto the Mentimeter. We haven't got, no, I can't quite see how many are logged on yet. So anyway, basically, if people are happy to log on, in a sample of 19 OECD countries taking part in the patient-reported indicator study, what position did Wales rank for quality of healthcare? 10th, 13th, 19th. So this is in 19 of the countries. So I might have to ask Rob what OECD stands for.
It's the Organisation of Economic Countries, something or other. It's
okay,
the same people that run the PISA study for education.
Perfect. That's brilliant. So thank you. Sorry, I promise I won't keep asking you things like that. So, okay. So the majority of people have gone with 46, which meant that we came 19th. Should we see what the answer is, please, Sam? Absolutely. So basically, you know, we are the worst out of those 19. So absolutely, for quality of healthcare. And that's one of the reasons why we've really got a quality-based approach at the moment. We're really, really trying to do the right things, but do the right things that are going to give the biggest benefit. So in the same study, trust was measured on a scale between 100 of high trust and 0 of low trust. What was the average score for Wales? So was it 48, 65 or 78%? And then Rob's just said in the side chat that this is a public perception of quality, not actually a measurement of the quality of care. So this is all about the public's thoughts. Just wait for you all to respond. I think most people nearly there. Okay, so the majority of us thought 65. And actually, it was actually 35% of us got it right, and it's actually 48. So really quite low number for low trust. So not doing great with public perception at the moment. In the NHS Wales performance framework for 26-27, there are 50 performance metrics. How many relate to patient outcomes? Well, I can tell you how many of them relate to children's patients' outcomes, and that'll be 0, but it will be changing in the future with our children's prom, but also with the hopefully with the quality statement being published, where we've made sure that proms are included in that as an essential part of care. So is it 0, 7 or 15? Just seeing how many of you are responding, and then we'll... So most of us have thought 7. Let's see the answer. Yes. Oh, no, sorry, 22%. So actually 22% got it right, none of them. So interestingly, when I said that none of them will apply to children's proms or children's outcome measures, actually none of them are thinking about anybody's outcomes or value. So really interesting about that. So the NHS Wales budget is 12.6 billion. What is that as a percentage day-to-day spending of the total Welsh Government budget? This is interesting. I don't know the answer to this one. Is it 35%, 45% or 55%? So the majority of us think, 68% of us on the call think that 35% of the total Welsh Government budget. I think it might be higher, but I haven't voted. Shall we have a look? Right, actually 55% of the Welsh Government budget. It's interesting, isn't it? So it isn't about not having enough money, it's about how we're spending it and how, you know, and that's why having the most valued and most effective treatments for the best value for the population is so important. So next one, please. I think there's one more question. Oh no, there we go. That's the end of the quiz. So yeah, we didn't do too badly this time, but always I think if we did it at the end of Rob's talk, things would be different. So I'm going to hand over to you now, Rob. Thank you very
And
much for coming.
fantastic. Thank you very much, Claire. I hope I can live into at least some of that introduction. Welcome everybody. I guess we put those in at the beginning because trying to paint a picture of what the value philosophy around healthcare is really, and I think it's stark when we have a look. The value philosophy, as we'll come to in a bit, is about outcomes and cost per outcome. And I think as a system, we're not great at measuring either. We're better at measuring costs, but we often don't understand it in the depth that we probably need to get where we need to go. So the OECD study very clearly demonstrated that a group of what most of us would consider fairly comparable economies and countries, we spent the median amount in comparison to other countries, but still performed worse in terms of our population's perception of our services. I think that's really important. And this is a perception. This is what the population think about the way that we deliver our services, and it may be that some of those some of the promises are perhaps too high, but it may be that some of the delivery is not high enough as well. So yeah, hopefully useful stuff. So if we can go to the next slide, that would be great. So plan for today is I'm just going to very briefly talk you through the Welsh context and introduce you to value based healthcare. The idea is to whet the appetite. So for those of you that know a bit about value and are acting in that way, hopefully to get you involved in some of the more technical aspects and get us involved in your projects. And for those of you that aren't thinking in that way, just to introduce that way of thinking, and then to introduce you to a whole load of resources that hopefully again get you sort of able to turn some of this into reality and places to go to look for things. So next slide, please. So some of those resources, as was said earlier, they'll end up in the chat in a minute. So yeah, we go to the next slide. So just in terms of the Welsh context, obviously prudent healthcare is our guiding philosophy. One of the key elements of prudent healthcare is value. On the next slide, please. Our plan in order to deliver prudent healthcare is a healthier Wales, and within that we've got our quadruple aim. And again, one of the 4 primary aims is around higher value health and social care. And then if we go to the next slide, please. And then value-based healthcare. This is kind of the third tier in that framework, and it really represents the measurement and decision framework. So what I'm presenting today is a decision-making framework around which we can apply the philosophy of prudent healthcare to achieve a healthier Wales. And I think that's really important. It's a way of being. It's not a thing. It's not something that you can just grab and hold. It's a way of thinking. It's a way of delivering things, and it combines lots of different things together. So we can just pop to the next slide, please. So why do we need something like this? Well, we know that I'm a big fan of behavioural change. My previous history is as a consultant physiotherapist in musculoskeletal care, and we know that an enormous amount of healthcare is about individual behaviours and how we respond to different things, and how we go about managing illness, particularly long-term chronic conditions that can't be cured. And I think this model I really like. It talks about a rider, an elephant, and a path. And if you're trying to get an elephant to move in a certain direction, there's very little point in asking the rider, because even if the rider wants to go somewhere, convincing the elephant to move is going to be tricky. So we need to get better at speaking to elephants, so our emotions, and we need to get better at addressing our environment. So this idea that yes, we need to think in a value-based way, but we also need to feel in a value-based way, and we also need environmental nudges so that we can work in a value-based way. So we need various tools and capabilities and things around us that allow us to make use of this decision-making tool. And that's what the national and local teams are here to do, is to develop those things which start to give us capability, opportunity, and motivation to deliver in this value-based, prudent way. Next slide, please. So as a directorate, we've been through several iterations. So you've probably heard of the Value in Health Centre, which was set up with Sally Lewis many years ago. That transformed into something called DTIV, which brought together other collaborators together into one organisation. And then that has since transformed into the Value Transformation Directorate of NHS P&I, and we anticipate being a part of what will be a fourth change, and hopefully the last one for a while, into a directorate called Improvement and Transformation. So bringing the improvement teams and the transformation teams together. So just to say there, that's our vision, which hopefully makes sense. But what we're trying to do is place value-based healthcare at the heart of an enduring NHS, where data informs decisions, innovation drives progress, and technology personalises care. And the most important bit is so that we deliver what matters most to the people of Wales. So our directorate is person-centred, it's clinically led, it's data-informed, and it is technology-enabled. And we have these four sort of primary functions that we do. So we look at what matters to people, we turn data into insights, we enable care closer to home through virtual and remote solutions, so any sort of virtual or remote solutions we can get involved with, and we look very much at digital technologies that could help us to move in that direction in terms of higher value. Okay, next slide please. Just skip this one for a moment. I might come back to it, otherwise I'll end up on a soapbox with that one. I decided to change that one afterwards. If you do get these slides after, they're basically 3 books that I would highly recommend, but we'll come back to it at the end if we've got time. Okay, so I just wanted to introduce you to the value-based healthcare model. Just to say, as I said before, it's a combination of sciences, so it's not a single thing. It's not like the improvement model where we can have a single sort of description of something, plan on a page that we can do in a year. It's a growing philosophy and a growing way of working. We are, as yet, internationally, there is no single methodology for combining the data that I'm going to talk to you about, which means that this does still remain as a value judgment. But the point of it is that we bring the various sciences together so that we are making data-informed decisions. Unfortunately, we're not at the point where we've got an algorithm where we can pop the data in and go, yeah, that's high value, or no, that's low value, or who that high and low value is. We're working on that currently and working with international collaborators on that. So we go to the next slide, please. So put really simple is this value equation, and this is why one of the reasons that I love it, because there is something on here that everybody across healthcare and the population wants. One of those things is outcomes, i.e. I want the best possible outcome that I can achieve for me as an individual, and costs. So how much is that going to cost me as an individual to do? How much is that going to cost society? How much is that going to cost the NHS? But also, how much does that cost environmentally and socially? So in terms of my local environment. And so we talk about this idea of triple bottom line with the costs. So it's not just about cash, it is about the social costs of delivering things, and it is about the environmental costs of delivering things. And we'll come back to some methods for measuring those later. And it's importantly, I think, for mostly for the clinical audience, it's and the people's audience, it's about outcomes. This isn't about driving down costs, it's about improving outcomes. And in the Porter-Teisberg model and where it has been implemented so far, actually that focus on delivering outcomes that really matter has a very pleasant side effect of reducing costs and enabling you to then do more. So what we often find when we employ a value-based healthcare situation, we stop doing certain things that are of very low value. It enables us to focus on things that are of very high value, that get better outcomes, and that frees up a resource to do more of that stuff. So that's what we would be aiming for. At the bit on the left about value is we talk about it at 3 different levels. Micro, meso, macro is the trendy way of saying it, but for the rest of us, that's about the person that's sat in front of you in clinic at the micro level. So how do I make a decision with this individual that is value-based? Meso in terms of my service, how do I make decisions about what my service does and doesn't do? And then macro at the population level. So I guess what Claire was just describing at the beginning there is that use of a PROM can be used in a one-to-one interaction with a patient. You've just told me this, and actually perhaps it's something you wouldn't have told me that if or I wouldn't have asked about if you hadn't just given me this PROM. And so now we're going to have that conversation because I can see that that's really important to you. It might be at the service level where we're finding across our service this intervention that we provide is only helping 1 in 10 people, or now we understand that the 1 in 10 people fit this profile, and therefore we can use that intervention more appropriately. Or it might be at the population level where we start to say, well, how they are delivering this thing, and it's getting way better outcomes at the same cost as the way that it's being delivered in Cardiff and Vale. Therefore, we should have a look at the way that those models work in terms of doing that. So that's the basic concept around it. Next slide, please. That's been added to by a chap called Muir Gray at Oxford University, and he talks about 4 types of value. I'm not going to go into these in detail, but just really briefly, the technical value is this a good outcome? I.e., when we do that intervention, does it do what it's supposed to do? Does it? It's the Ron Seal effect. Does it do what it says on the tin? Yeah. Did it lead to a change? And it's surprisingly how often we will be applying, albeit evidence-based in whatever definition of that is, interventions, but actually the technical outcome is still not great. The second one, which for me is the most important, is the personal outcome. So is this a good outcome for that person? So we all know that applying the right thing to the wrong person at the wrong time isn't going to get you a good outcome. And so it's about, are we applying the right thing with the right person at the right time? And what does this mean to them? And this is where we get into very much about that person's values, their goals, their aspirations, their needs, their wants. And is this something which fits with their values and their way of being and achieving what they want to achieve? Third one is allocative, which I think we're all really interested at the moment. This is about cost per outcome and where we choose to spend our cash. So we'll all be aware that I don't think anybody's going to be shaking the money tree and giving the Welsh NHS more than 55% of the entire Welsh budget. And therefore, can we be confident that what we're doing is the best use of that resource? Is there some things that we should perhaps do less of, some things that we should do more of? Are there different ways of delivering the same thing? So if I give you an example, in my practice, we shifted a method for treating back pain and osteoarthritis out into community settings using some rehabilitation coaches. We reduced the costs to 20%, so we reduced it by 80%. Of delivering it. We actually got better outcomes than we were in the first place, and so that gave us a large wodge of cash that we could then put back into meeting some rehabilitation needs that we weren't meeting elsewhere in the system. So it's really transforming the way that we look at what we're doing, and if there is a higher value way of doing it, we should be looking at that. And then the final one is social. So is it a good outcome for society? And we'll come back to social return on investment later, but these are things like for you guys, the importance of education. So we know that children receiving education and being in school is incredibly good, not only for their health, but for all sorts of factors throughout the rest of their life. And therefore, we should be looking at prioritising that. In my field, it would be very much more about work, as if, for instance. But those sorts of things are important. Caring responsibilities, all that type of stuff. Okay, next slide, please. Okay, so put really simply, when you apply these techniques and you do your equation, what you'll end up with is some kind of assessment of, well, here's the size of the outcome and here's the size of the cost, wherever that might be. And if you're comparing that across different pathways or different methods of delivering something, you would be able to have a data-informed decision about this is of reasonably higher or lower value than doing it that way. And the idea being that we get to the point where we can define low value opportunities, and we would look at either restricting them or stopping them. So the in-use are a good example of that. Interventions that we know that things like NICE don't recommend because they're either harmful or of very low value. Things that are in the middle, we might look at adapting them. How do we improve the value for them? And that's where improvement methodology would come in. And then things with higher value, we would look to spread and scale them. So, you know, why are our population not getting uniform access to this really high value intervention, and how do we go about achieving that? Okay, so it's a decision aid in that respect. I guess on this, what we're not really great at is either the top or the bottom of this. Yeah, I would say as a system, we're great at adapting things and we're great at small amounts of continuous improvement. In general, healthcare is really bad at stopping doing things, and it's really bad at spread and scaling. So we've got some brilliant exemplars. If you look at things like Bevan, things that have demonstrated really huge value, but they don't get outside of the hospital that they were invented in. And that's where people like Claire are here to try and coordinate us and encourage us in that. So next slide, please. Okay, so what do you need to do value-based healthcare? The Scottish have got a really good way of describing all of this. And so as much as I hate it, I would say if you want the basics of it, go to the Scottish model. It's much more friendly in terms of its approach towards the clinical front line. It's designed to speak to the clinical front line. The Welsh methodology behind prudent healthcare and a healthier Wales is much more philosophical. So, but it is identical. They are modelled on the same thing. It's the same skeleton. It's just got slightly different skin. They talk about a culture of stewardship, which I think is really, really important. And then these four things. It's about segmenting population. So thinking about how we are addressing people. I use an example from my speciality. We have 3 different ways of delivering musculoskeletal care within primary and community care for 3 different things. And when you look at it, they all do the same thing. Another example might be in cardiac and pulmonary rehabilitation. A non-expert sat in the room of cardiac rehab or pulmonary rehab would probably be seeing the same thing happening. And yet we persist with dividing things up. So this idea of what's the need of this population and how do we deliver that need that enables deliver things at scale and pace and all those sorts of things. Integrating systems, key part of the real positive for us in Wales. We are supposedly an integrated system. We still need to go a long way to realise that, but the benefit of integrating a system and having seamless flow across that is one of the value principles. Really important is outcome measurement, which comes back to Claire's point earlier about PROMs. And just to be really clear there, it's not all about patient reported outcomes. Yeah, that will tell you the personal value. It won't tell you the technical value. So clinical reported outcomes, technical outcomes are still really, really important, but we need to balance those with the impact on the individual. There is no point having a really good technical clinical outcome if that's not what the patient desires or the person desires or what they're trying to achieve. And the final thing is that actually that focus on outcomes, that focus on quality has this nice side effect, most often as of cost reduction somewhere in the pathway, which enables us to build the other bits. Okay, next slide, please. Okay, so you may have seen this model floating about. It's something that was introduced many years ago. So the idea of in the Welsh Valuing Health Centre was to split the pathway up into 5 sort of areas that we can focus on. These 5 areas are pretty much common across any condition or any patient group or any population group. And the encouragement is to look across the whole of that pathway to find where the high value opportunities are. And I guess this links into this idea in the political context at the moment of this idea of shifting left. So we do lots and lots of optimizing interventions. We do lots and lots of work in that area. We do much less in the preventative space and the accurate diagnosis space. And we know Public Health Wales will tell you, we know that the advantage of investing in prevention is that it is, in terms of costs, it's far more effective, and in terms of population health, it's both more effective and more desired by the population. So by doing this in these sections, what we encourage to do is take a whole pathway approach with your segment of your population, consider each of those, and hopefully get to the point where you're looking at shifting resources to where they're most needed at this point in time, but also most needed for the future, and where they offer the most value to get you the best outcomes. Okay, and the next slide, please. You'll be able to tell from this that data is really, really important to this. The whole thing is built on this being about data, and data to inform a decision, not necessarily because it's the best decision or the right decision, but because it's the best decision on the basis of the information that we have right here, right now. And so having accurate data and having data that we trust and that we can understand and that we use is really, really important. And there's something really important in there about data standards. I would say as an organisation, the NHS is data rich, but it's knowledge poor, because often the data that we have doesn't actually translate into something meaningful that we can use. So despite the fact that we've got buckets and buckets of data, is it the right data to make sense of, and can we make sense of it? And so the team many years ago came up with this idea of a CAPU, as they call it. And so when we're looking at any sort of data collection, be that clinical, technical, patient reported, whatever that might be. We need to think about how we're going to collect it, how we're going to do that in a way that doesn't interrupt care delivery. So you'll see a lot of online methods, you'll see a lot of in-clinic collection methods using digital devices in clinic, for instance, where it can be done outside of the consultation, and that information is then delivered to the clinician in the consultation. The combination analysis becomes really, really important. So is the data coming in such a way that we can combine it with other pieces of data across the system? So the metadata, things like demographics, things like comorbidities. And are we analysing that in a way that we all understand and agree, and leads us to some form of knowledge, as opposed to just a number, which doesn't necessarily mean the same thing across the system. The presentation and utilization then becomes really, really important. So are we presenting that to the right audience in the right way? So in clinic, I'm going to want data in a certain way to use that with an individual that's sat in front of me. When I'm in my office and I'm looking at a service level, I'm going to want different data. And then when I'm in the national space, I'm going to want a different view of that data. And so are we doing that in the right way for the right person? And again, those sort of subtle differences perhaps between operational needs and clinical needs, those types of things. And then most importantly is the utilization. Is the person that this is designed to help, do they want it? Are they going to use it? And are they willing and able to make decisions off the back of it? And I would say in the work that Value have done over the last sort of 5 to 10 years, that's probably the crux of it. We do find that once the investment in terms of getting through the rest of the process is there, because it does take time, often you've lost the people that it was intended for, or the world has moved on, or various different things. So we really need to be thinking about that up front. What is it that we need for this scenario? What's it going to look like? How are we going to use it? And I guess coming back to the elephant, what's the benefit of it for me as an individual clinician to do this and to look at this, or for me as a service lead? So yeah, would really encourage this model. And you want to do it up front as early as you can in any processes that you're looking to put any sort of data into practice. Okay, next slide, please. Okay, just to say then that if we've got the data rolling in, what we can then do is to create dashboards. There's a link in there for you to be able to see these. At the moment, there isn't anything about pediatrics within here, but you'll see the ones that have been picked off so far by the Value team. There's lots of them. We're in the process of getting patient reported data into there alongside some of the clinically reported data. We're also in the process of repatriating national audit data. So for you guys, there's a really important piece of work that's just been approved in diabetes, which will enable us to be able to see the primary care diabetes national audit return, and pull that across and link that into all this other outcome data. So you start to really build up a picture of what care looks like. If you want to have a look at one of them, I would encourage the hip or the knee arthroplasty dashboard. They've been around the longest because of the political imperative around waiting times, and they are the one that's been used the most. And so the Orthopaedic Network are really utilising that in everyday decisions, in decisions about how they plan their services, in how they meet crisis. There was a crisis in bone cement a few months ago, but they're using this data in practice to really, really high value. So yeah, worth a look in terms of the art of the possible. Next slide, please. Okay, that's just it's just a look at the diabetes data. I don't expect you to be able to see that, but you can see the visuals and things that are there. Some of this is really great at service level, some at individual patient level, so on and so forth. We also have these types of visuals available in Welsh Clinical Portal. So we've just built one for EQ5D5L, so we will be able to do that for you, Claire, with the youth version of that, where you can see an individual trajectory over time, so you can see what's happening to their patient reported scores. We've got people in so the pre-op environment is probably the most advanced for this, and heart failure, to be fair. They're using it to adjust medication, to optimize medication. They're using it for PIFU and SOS, so that idea of identifying people at a low and higher risk. They're using it to navigate care. So when you get put on a waiting list in Swansea Bay, as for instance, you would get something through to fill in, you fill it in, they risk stratify you, and then they would offer you various different interventions or a conversation or a coaching conversation about how you manage your time on the waiting list and what you do in the meantime. So yeah, it's useful stuff when it's applied. Okay, next slide, please. Okay, I love this model on the left, and I guess that sits to my my sort of probably the reason why I'm into healthcare leadership rather than clinical delivery at this point. And I think this applies to data as well. So what we often see is that everybody wants data. Very few people trust the data, and then deciding to make a change on the basis of the data is often the most hard bit. So again, that's coming back to our elephant model, and I think we have to be willing. And certainly the conversation in my department when we talked about implementing PROMs was, are we ready to learn that actually our outcomes aren't as good as you think they are? And I think there is an inherent risk as a clinician there that something isn't going to come out quite as good as you think it might be. So yeah, there's some bravery involved, I think, in terms of this. Okay, next page. Okay, so this was just to go through some of those tools. How long have I got left, guys? I don't want to linger on them for too long.
Sorry, I couldn't turn my back myself, but you're absolutely fine for another,
We're good, are we?
you know, sort
Okay.
of 10 minutes or so.
Oh, brilliant. Okay,
Yeah.
I'll go for 10 minutes then. Cool. So yeah, just to talk a bit about patient-reported data, because I think that's the most important bit in terms of value. It's all about person-centeredness, and so hearing the person's views is the most important bit for us. Different parts of our system have different levels of maturity in terms of that ability to get that data, either in one-to-one consultations or through other means. But this bit, it really is all about, can we use it in direct care and in terms of assessing outcomes? So next page, please. So this is something called ICHOM. If you haven't heard about it before, it's the International Consortium for Health Outcome Measures. What they do, so they're across the globe. We're an official partner of them in Wales. And what they do is to create internationally agreed data sets for outcome measures across various different pathways. So again, it would be end-to-end pathways, condition-specific pathways, or parts of the population. So if you go to the next slide, please. So I was on there basically what comes with it is an IT-ready data set. So it's all mapped across to SNOMED. It does all the codes. It's got the fire standards, which is the bit we talked about earlier. That's what you need for data to travel in Wales. So if you're ever looking at anything and it talks about data standards, if it's not fire standards, then it won't work in Wales. Okay, you need providers to be able to do fire. If it does that, it will work in Wales. It will go wherever you want it to go. And it can be used by the people you want it to be used by. They come with a data dictionary, which makes sure that the data going in is of high quality. So when you pull it back out, you can trust it. It comes with a published manuscript in a peer-reviewed journal, which gives it that obviously credibility. And then the reference guide comes with it as well, which will detail exactly how to use it. Next slide, please. Should be. Yeah, the overall pediatric health outcome measures. So this would be a good data set for you guys to have a look at. Essentially, it's as I understand it, it's for the entire sort of child health population, and it uses validated tools. It's internationally agreed, so you'd be able to start to benchmark internationally. And as you'll see on the model there, so each of them comes with these models. They cover these different elements of functioning, so things like social functioning, physical functioning, or mental functioning. And you'll see on the right there, they're all internationally approved and accredited and validated outcome measures. So if you align to these, you can't go too far wrong, and you will find international benchmarks that you can rub up against and compare your data internationally with. And then I went through their data set. If you pop to the next slide for us, there's not masses for children and young people, but there are several others. So yeah, next slide, please. So there was a whole section on congenital anomalies, which I'm guessing would fit with you guys. There is a specific anxiety and depression for children and young people, neurodevelopment disorders, and pediatric epilepsy. There are other conditions that I was seeing on that cross the adult and child population, but these were the ones that sort of stuck out as being specific. But the link's in the chat, so if you go and have a look. if you were to want to develop a data set, then we can work with ICHOM in terms of doing that. Okay, so there is an opportunity there. Okay, next slide, please. Okay, so that's kind of the patient reported bit. I guess what we're probably all really interested in, and I think you guys probably more than anything else, is how do we prevent stuff, and then how do we measure what didn't happen. So this was one of the big problems that I have in the rehabilitation world, is that if we apply early rehabilitation or preventative rehabilitation, or palliative rehabilitation, then, and you're trying to stop something happen, how do you measure it? How do you measure what didn't happen? And this is just to say there's a few methodologies that we can start to think about within that space. So next slide, please. So this one's called Most Significant Change. It's a qualitative methodology. What it enables you to do is to ask a group of people, what is the most significant change that happened when we did X? So when we put this person on this ward, what was the biggest change for you? Parent, child, carer, nurse, doctor, physio, whoever it might be. And what you end up with is about 10 to 12 descriptions, really small. You give them a very small piece of paper, so they have to be nice and brief. And then you would run a forum to say, well, which of these most accurately describes the significant change that's happened? So it's often qualitative stuff, which isn't particularly measurable in terms of outcomes, but is really measurable in terms of experience. Can be really, really useful in terms of evidencing some of the stuff which is not so easy to evidence. Okay, next slide, please. Okay, I've been plugging this for several years since I first heard about it, and this is called the Healthy Days at Home measure. In theory, this exists. There's a national version held by DHCW, and there are versions in each of the health boards and trusts. It was initiated by the Strategic Programme for Primary Care many years ago. It's gone very quiet, and we're in the midst of a resuscitation attempt for it because we feel it's really, really vital for community by design. But essentially what it does is it allocates a number of days or hours to various healthcare or social care interventions. So as an example, a community care visit might be logged as an hour, an A&E attendance might be logged as a day, an admission in hospital might be logged as 5 days, an elective admission, however many days that was, an emergency admission, a diagnostics appointment a day, so on and so forth. And the idea being that you can adjust the weighting of those depending on the perspective that you're looking at this from. So you could weight it all to costs, you could all weight it to the impact on the individual, you could weight it to the impact on the delivery of healthcare. But what it means is that by the end of the year, what you would end up with is a measure of how many days that individual was healthy at home, and how many days or hours they were receiving healthcare. And so when you put a preventative intervention into a system, you would be able to see the step change in your graph in terms of, okay, before we did this intervention, they were healthy at home for 150 days of the year. After the intervention, they're now healthy at home for 250 days of the year. That's got to be a good thing. So this is in the process of hopefully being resuscitated, but it's really, really important, I think, for the prevention agenda that we're looking at, and we could look at different ways of adapting it to different population segments, as we described earlier. So hopefully some news coming back on that soon. Next one, if we can. Okay, and then I think these are probably the last few. So this is in that sort of social value section that we talked about, and there's a whole team that we've just discovered in Public Health Wales called the Weave team, who are looking at social value and the impact in that population health and prevention. So they've got this e-guide for how you go about calculating social value. And if you go to the next slide, there are two methodologies. So next slide, please. There's two methodologies. The one is SROI, which is social return on investment. We've got various teams across Wales that can do this. The second one is the social cost benefit analysis. So there's slightly different ways of doing the same thing. They're linked through to health economics. They are starting, it's a fairly new methodology. It's not as robust as a full health economic analysis that somebody like FD&P, the financial guys, would do, using their costing methodologies. And we'll talk about those briefly in a minute. But they look very much at the impact across society. And so this is where you will hear things like the social return on investment. The back pain thing I was talking about earlier showed a £6 return on investment for every pound that we spend. The interesting thing for me there then is about who is the beneficiary of that return, and then can we start to use that information to work in partnership. So if that beneficiary, for instance, in the work that I was doing, are employers, then there's a nice collaboration to be had there between employers and the NHS in terms of delivering, for instance, occupational health. Obviously, there would be other things there around, government agencies and various different things. So interesting methodologies, and there's a team at Public Health Wales that can help you out with that stuff. Okay, next slide. Okay, just before I come to this, I will talk you through some of the costing stuff, because I think I've got a couple of minutes. So there's two methodologies for costing which form the financial element of it. One is very specific to individual patients, and one is much more broad across services. But what they enable you to do is to put a price on the cost of delivering a service. So the example I gave earlier with the back pain one, we could deliver 12 one-hour sessions of community rehabilitation and education for £22 per person. To deliver the equivalent, the variation in a physiotherapy department cost £164. So we can immediately say, well, delivering that is better if the person is appropriate for that. If they're not, that's fine, but if they are, that's the one that we should be preferring. The environmental costs, there's a group called Sustainable Quality Improvement, which I can link you to online, and they will link up things like carbon footprinting and all of that type of stuff. And we're in the midst of working with a group in Welsh Government to bring some of those resources to the NHS, so that you can really have a look at the enormous environmental impact that healthcare has at the moment. The reusable plastics and the gases stuff is really quite frightening. And some brilliant work happening across Wales, particularly in ICU. I'm sure it's the same in Peds ICU in terms of the way that they're looking at that. So yeah, the social, the economic and the environmental, there's tools there to do that. So I guess the last thing for me is just to have a very quick chat about the reality. I think the desire of the system and the aspiration of the system is at the moment probably well beyond its capability. So we have to bear in mind, those of us that really want to work in this way, the system isn't quite geared up for it yet, but it is moving in that direction, and we're trying to move it in that direction as quickly as possible. But that can feel frustrating if you really want to work in this way. And let's be honest, with what you saw earlier, at the moment, the priority tends to be in terms of measuring inputs rather than outcomes. It tends to be a much more paternal approach over person-centered care, although that is shifting, and shifting very positively in my view. It does tend to be very much focused on short-term improvement rather than long-term transformation. But again, that's where P&I comes in, and this new improvement and transformation directorate to start shifting the dial on that. And there is a real focus, I guess, a risk that the quality agenda brings us to a focus on doing things right without thinking whether we're doing the right things. So we know that it's very easy to do the wrong thing right. But sometimes we have to look at whether the thing we're doing is actually the right thing to be doing in the first place, again, for the individual that's sat in front of us. And then just that caveat that there is no single agreed methodology. It's a bit of a murky puddle at the moment. We will be making it clearer this year. We're creating various frameworks and things this year that will really help people to apply it. But we are still learning, and that's an international fact at the moment. And then just lastly, I probably don't need to say this to anybody, but digital infrastructure is it's a barrier, to do all of this and to collate all of this stuff. We do need a good digital infrastructure, and I'm very confident that Amazon know much more about me, my values, my beliefs, my preferences than my GP does. And we need to sort of start addressing that balance, really. So just the final slide. It's just to say, look, value-based healthcare is a model. We know that all models are wrong, but this is one that I think is very useful. It's also in policy, so we should be having a good go at trying to use it. So thank you very much.
Fantastic. Thank you so much, Rob. That was absolutely brilliant. It's given me more questions than answers. But yes, we've got a few questions for you in the chat. But can I just say one thing before we move on to the questions? So with regards to the National Children's Prom, what's happened is we reviewed all of the different available children's proms, and then it went through the clinical reference group and the prevention subgroup. And then one was chosen, which is, as Rob mentioned, it's the youth version and the children's version of the EQ5D5L. Now, the reason why we like this one is A, because it's really sensible, it's really simple, but B, because it's also extensively used in all the adult specialties. So the good thing is that we can then get that really like spectrum of information moving on from children right up into transition and into adult healthcare. So we've applied, so that's the one we're going to be going with. Now, I know that there are some specific, sorry, Rob, I was going to say, I know there are some specific ones that, like, there is a new one for diabetes. The only two we've actually got in Wales at the moment for children are diabetes and tonsillectomy, but no one's ever used the tonsillectomy one. So, but the diabetes one is being used. There will be disease specific ones as well, but what we're hoping people will do is that people will use the national one, and then if they've got a disease specific thing, then they actually do that as a bolt on, because it's really important for us to really understand our population and really be able to get that sort of that wider picture, and it'll start really be able to show us what's needed in the different areas and things. So we've applied for the license. It takes time, and as soon as we have got the license, it will be uploaded onto the platform, and no doubt we'll probably do another webinar, and we'll be doing lots of information sharing with all of you and things. So just to mention about that. So the link that you've got in the main chat is just to the main website, not this specific children's one, because at the moment we've only got permission to share it to be able to actually for us to view whether it is the right one for us to use. So anyway, sorry, Rob, you had your hand up.
Yeah, I was just going to say, we would always recommend, when you're starting with a broad brush like this, something generic. EQ5D is internationally renowned. It's the one that you calculate collies from. It's got multiple uses, and I think it's a really good place to start. And definitely starting small and building is very sensible.
Brilliant. Yeah, and I have to say, having read all of the ones that Sarah Fintona, who is our PROMs expert, sent to me, this one was just streets ahead of the rest of them, and also it's just so comparable to everything else. So yeah, so anyway, some questions for Rob. So databases, really interested in the database, and I see someone's put in the chat, so how will the database link in with, we've already got a children's waiting list database, but it is very just waiting lists. So how can we develop one like the one that you showed us? Because that's got so much more useful things than just waiting lists.
Yeah, so in terms of the dashboarding, we can link it. So we're very lucky to have a team that we work with closely in DHCW, and basically, if there is a data stream that goes into DHCW, you can link it into these dashboards. So you'll see in the hip and knee arthroplasty one, there's a whole page for waiting lists. The real advantage of doing this really well in following the data standards is that it enables you to link because it's all patient identifiable. You can link the data, and so you'd be able to, as an example, see the change in PROMs as somebody is waiting. So if you were to say, well, show me all of the people that are waiting for X across Wales, what's their pre-PROM, what's their next PROM, what's their next, well, you'd be able to see whether people are getting worse over time or better over time and that type of thing. So yeah, the beauty with those dashboards is that they are fully integratable because we use the DHCW data streams. You just need to bear in mind that not everything at the moment goes through DHCW. So there's a particular gap around primary community care data. We've got an objective to work with the DCMO this year to try and improve on that. But basically, if there is a data sharing agreement for something, if it goes into DHCW, it can be combined at an individual person level right up to service level.
Fantastic.
But just to say with those as well, so we're putting registry data back into those as well. That follows the same principle. So
brilliant.
Yeah, if it flows, it'll come in.
We're really lucky in PNI because we've obviously got you, and so we can pick up the phone or Teams you and say, how do we get a view of all the projects we're doing to make sure that we are thinking about it from a value-based perspective? What do people do who are in the house boards? How do they access how do they access their equivalent review?
Yeah, brilliant. So each of the health boards and trusts, Velindre and the 7 health boards and Public Health Wales all have a version of a value-based healthcare team. So yeah, you will find them within your system. If you can't find them, drop me an email and I'll tell you who the lead is. They're set up slightly differently in different places. So some of them sit under finance, some of them sit under digital, some of them sit under improvement. But there are teams in every health board that you can go to about this stuff. We work really closely with them, and we'll be working even more closely with them over the next year. So yeah, you can either come to us nationally and we'll signpost you. It will help you if we can, we'll signpost you if we can't, or go to your local value team.
That's amazing. Well, if you've got any of the names, we can always pop it into the Padlet. That would be really helpful because we could then, people can share. Because I have to say, when we've been out and about doing health board visits, it's been really, really helpful to have the value team sitting in there because, they're. I'm obsessed with saying to people, have you evaluated it? And actually, if you get a value view of what you're actually doing, you will then think about it in the beginning and at the end, rather than trying to work backwards.
Absolutely.
No,
Yep.
absolutely.
I'll get that over to you.
Yeah, that would be fantastic. Thank you. So we're quickly running out of time. So what we just wanted to do, I'll just make sure I haven't missed any other. Yes, so basically just some questions for people. Just back to the Mentimeter. What does your team need to help promote and embed value-based healthcare? What can we do to help you? What can P&I do which would support that? We're definitely trying to have so if you wouldn't mind all logging back onto the Mentimeter and then just popping in anything you can think of, because obviously, both Rob's team and our team, we're here to support and help, and actually we're definitely trying to get that value lens on everything we do, because can't do everything, so we need to make sure we're doing the best value, and most effective for that value. So so if you're happy just to pop some bits in there. Oh, that's disappeared, sorry. Yeah. Oh, it's okay. That says feel free to answer in the Teams chat. Sorry, I completely missed that it said that. I'm really not on my A game today, am I? So anyway, next slide, please, Sam. On a scale of 1 to 10, did the webinar meet your needs today? Fab. So I think it's one of those areas that the more you start to look into it, the more you become quite passionate about it. I'm definitely a convert now. So we'll just wait for a few more people to answer. It's a bit of a lag today on the Mentimeter. The other thing that somebody asked in the chat, Rob, while people are doing this, is they were asking about how you can get, the input from the children and young people, and how we, because obviously they can complete this, or their carers can complete it with them and things, but how else can we get that sort of view? Oh, you're on mute.
Sorry, yeah, there's a whole different range of the patient reported stuff. So you'll hear people talking about PROMs, which is family reported. There's a CROM, which can be a carer reported. So yeah, there's different tools which are designed for different people across the system. I guess to say in the pediatric and the children and young people environment, I would say it's the least developed because of the things around consent and capability. Most of the stuff has been focused on adults, but it's slowly shifting, and the learning is shifting across. So yeah. And I think it's obviously it's really important, isn't it, that you're getting that holistic view in terms of the impact.
No, that's great, and I have to say, everybody's heard me say this a million times, but the one thing I know is if we try and plan services without involving the babies, children, young people, then we never get it right, and we will be told we haven't got it right. So yeah, absolutely. So next slide, please, Sam. So what will you take away from this webinar today? So if people can just pop it in the Mentimeter, this is just for us to have a word cloud, please. My timekeeping is rubbish because everyone's probably running off to clinics now. So inspiration, that's lovely. Inspired. Hopefully everyone's going to be running off to try and find out who their value teams are in the health boards now. So Peds Health Circle. Yeah, absolutely. I thought that the chart that you showed us about the healthy home, the healthy days at home,
Yeah.
was really interesting. I'd like to know more about that. Is there some of that in the Padlet? There's some information about that.
Yeah, so there should be a link to the home page for it.
Yeah, brilliant.
Kieran, if it's not in there, remind me and I will send it across. But yeah, there's a page on the strategic program for primary care about that. As I say, it needs a bit of revival, but we're in the process of doing that at the moment.
Fantastic. And then next page, last page, future webinars. So we do evaluate every request that comes in. We've got a tally of how many things have been asked for. And the next one, I've completely forgotten what it's about. Kieran, can you help me, or Sam? But basically it's the most asked for subject on your list. Can somebody in the team help me?
It's vaping and smoking.
That's right. Sorry. Popped out of my head. So yes, the next one's going to be about vaping and smoking, which I think is really, really topical at the moment. But what we do is we do evaluate everything that everybody says, and we then put them on. Healthy weight, definitely. We've done one on healthy weight, but our main focus in the next year for prevention is on obesity, healthy weight, working very closely with Rachel Bath's team in Public Health Wales. So that is definitely going to be another one that we'll be doing. Sleep. Yeah, no, that's fine. I think sleep's on our list. Early years and play. We've had one of those just recently. So there's one on our website if you wanted to look back. Anyway, I'm going to let everybody go because I have to say I've managed to social media safety. That would be a brilliant one, actually. It's a really good idea. I think online safety is really important. So toileting as well. So yeah, we'll and obviously if anybody has any ideas for good speakers and people that you'd like to hear from, we can approach them on everybody's behalf. So thank you everyone for coming along today, and most importantly, thank you to Rob for your fantastic talk. It was really, really, inspiring, but also really, so much information. So it was great. Thanks to the team, very well organised as usual, apart from the chairing. And we will see you all very soon. So thank you everyone for coming.